Kia ora, good afternoon. My name's Julie Collison. I'm an occupational therapist, hand therapist, and I work out at Module 5 at the hand therapy clinic at Manukau Super Clinic. So my study was looking at patients who'd had metacarpophalangeal joint arthroplasty, and I'll explain what that is, to their joints, and I collected data on patients who'd had this operation. So just to give you a little bit of background on what this is. So the metacarpophalangeal joints are essentially the big knuckles on your hands. If you make a fist, they're the knuckles across here. And people have this operation usually from rheumatoid arthritis, but certainly from an inflammatory arthritis that causes destruction to the joints. And people may need to go on and have the joints replaced. And you can see here, this is preoperative, where the fingers are slanted over towards the little finger. This is what the implant, the silicone joint replacement, looks like. And after surgery, you can see these effectively form a little spacer where the joint was, and helps to straighten up the joint and to give extension back to the fingers as well. So they kind of go from a position looking a little bit like this to hopefully to a nice open straight hand. So the background to this is that traditionally after surgery we've used a splint called a dynamic splint that would look a little like this splint here with these elastics and outriggers. And the idea is that the splint supports the fingers during the first 6 weeks of healing to help the fingers to stay in extension and to help the soft tissues to scar up around the joint and help the healing process. These splints allow for early range of movement because this is an elastic here. People can make a fist, they can do exercises. The problem is that these splints are quite high profile, quite intrusive, as you can see, and there isn't really any good evidence to show that they are better than any other approach. There's no randomized controlled trials that show this is superior to any other approach. And there are different splints that have been described in the literature. So we felt that it was timely to review our management and to gather data, counties data, and to look at to see if there was a better option for our patients. So we wanted to, I wanted to investigate the outcomes following this surgery at counties, and also just to get some qualitative data on how patients found the experience of wearing these splints and what it was like for them in those 6 weeks. So I recalled everybody who had had this surgery between 2012 and 2000 in Auckland, and I took the measures on all those patients except for people in Northland. I had another therapist take those measurements, and I also did a semi-structured interview on 10 of the participants. So the outcome measures that I looked at were essentially joint range of motion, using what we call a little finger goniometer there, which measures the joint range of motion in degrees. I measured also wrist range of motion, strength of the hand using a dynamometer which tests your grip strength in kilograms, and I used some patient-rated outcome measures, self-reported outcome measures to look at function and also patient satisfaction. So overall, there were only 19 participants. This is not a surgery that has large numbers. Fortunately, not so many people have the kind of destruction to their joints anymore because of good drug therapy now for rheumatoid arthritis. So there was only 19 participants, total of 26 hands. Almost half of those people had both their hands operated. The average age was 62 and predominantly women, as would be expected in this cohort, predominantly European, but there were 2 patients who were Māori. And the mean follow-up time frame was 34 months. So I know there's a lot of data on this chart, but really what we're looking for here, the main change here is between preoperative measures and post-operative measures, and the key measures that we're looking at are extensor lag here, because that's looking at the change from how straight the fingers were before to how straight they are after surgery. So you can see here that there's a mean change of almost 50 degrees, and 50 degrees is quite a large increase in range of movement and extension. And then this here you can see that ulnar deviation, so that's the way that the fingers curve towards the little finger, so they kind of point off towards the little finger. That's ulnar deviation, and that was increased at a mean of 16 degrees. So you can see that they're both statistically significant, but they're also clinically meaningful changes. Wrist range of motion essentially stayed the same. Grip strength was interesting because patients sometimes complain that they lose grip strength, so we wanted to see if that was the case. And we did find that there was a small decline in mean grip strength of almost 4 kilos. And that might not seem much, but 10 kilos is not a very strong grip strength. Most people in the room here would have a grip strength of well over 20 kgs. And men who are doing manual jobs would have a grip strength of anywhere upwards of 50 kgs. Function, so just looking at the patient-rated outcome measures, there was a mean change for both the quick dash, which is the disabilities of the arm, shoulder and hand, of 20 points, and the patient-rated wrist and hand evaluation of 16 points. Again, that doesn't seem like a lot, but a meaningful change is described as 14 points for both those scales. So we wanted to find out whether patients were satisfied that they had had the surgery, and you can see that the data is fairly widely spread. Not everybody is 100% happy that they had the surgery, and this is satisfaction with operated hand and with the appearance over the previous week. But you can see that there is a clustering of the data towards the higher end of the scale. So people overall were I guess you could say they were happy that they had the surgery, though there were some who scored, under 50. So this is not a unanimous, we're really happy that we've had this operation. When asked about whether they would have the surgery again, all except one participant said that they were satisfied with the outcome of the surgery and that they would recommend it to others. So what I did then was look at our data and compared that with studies that had used, international studies that had used dynamic splints, the ones that we traditionally use, and with studies that used a more static splint, and I'll show you a photo of that shortly. So what we found here, again, I'm just going to pick out these two figures here, the ulnar deviation and the extensor lag. So you can see here that we had a mean the mean improvement was back to 6 degrees, which means that the fingers were nice and straight. They weren't pointed off towards the little finger, and that's better than these three studies here. So that's where our data was favourable in relative to those studies. And also in terms of extensor lag, our extensor lag is as good as, and if not better, except for this one study here. In terms of static splints, we also had favourable results. I won't go through all the numbers, but we had good outcomes compared with static splints as well. In terms of what people said about wearing the splints, we had a lot of I had a lot of data there, but essentially people found the splints visually challenging. They created a lot of interest for people. Some people didn't like the look of them. Of course, they were intrusive into everyday life, as any splint would be, but it was difficult for people to take clothing on and off, that kind of thing, with these high-profile splints. And that just shows you what some of the participants, what their hand was like pre-operatively and then after surgery. So that's as straight as that person could get their fingers. And you can see here this ulnar deviation has improved significantly. So the key findings were that our outcomes were equal or better than other comparable studies in the literature. That the dynamic splint, people did tolerate it once they got used to it, but was felt to be quite intrusive and difficult to manage. And because our outcomes were as good as other studies that were using static profiles, we felt that it was worth having a conversation with our surgeons about changing to lower profile splints that would probably have better patient acceptance. They're certainly easier and less time consuming to fabricate, and they may actually have better outcomes in terms of range of motion of the MCP joints. So I presented the findings of this in more detail to our surgeons and our hand therapy team, and it was generally agreed that we would switch from using the dynamic splint to a lower profile and hopefully easier to manage splint for our patients. So they look more like this kind of a splint here, where the finger joints are left free during the day. So we're now going to trial this on a prospective basis. Thank you.